Today, we're going to talk about a very significant and also a very interesting topic. Having known the fact that we have basically a central nervous system, and out of that, we get the peripheral nervous system, the peripheral nerves. Basically, we have 31 pair of peripheral nerves that are coming out of the spinal cord. So, apart from this 31 pairs of the spinal nerves that we have 12 pair of cranial nerves on the other hand. And these cranial nerves are basically directly coming out of our brain, either through the brainstem or through the medulla or pons, depending upon the different locations of these cranial nerves. So, exiting the skull through the different foramina, these cranial nerves have specific destinations and specific functions to perform. Having the core knowledge regarding the cranial nerves is very important over here. Basically, we have 12 pair of cranial nerves that we're going to discuss today in our lecture, and we're also going to discuss the significant pathologies and the significant clinical syndromes that are attached to these cranial nerves that we're going to discuss right now. So whenever you have a patient and you are suspecting that this patient is suffering from some sort of a cranial nerve disorder, he comes up to you basically with specific signs and symptoms out there. So you'd be looking for these clue signs, and after that you would be basically going through the major mainstream clinical examination of these patients just to find out which of these particular cranial nerves are involved. Depending upon their function, it is going to affect that individual. As we're going to go through these cranial nerves, we must have the basic knowledge. You have to refresh your basic knowledge that I basically assume that you already know that we have these 12 pair of cranial nerves, including the olfactory, we have the optic nerve, then we have the trigeminal, the trochlear, the abducens nerve, the facial nerve is there, we have the vestibulocochlear nerve, and after that we have the glossopharyngeal, hypoglossal, and finally we have the accessory nerve. So having known these pair of nerves, we know that there are specific functions that are attached to these nerves. For instance, we have the olfactory nerve, which is basically responsible for the sensations of smell to be carried to the central nervous system. Then we have the optic nerve, which is obviously responsible for the vision, and it is again attached to the occipital lobe of the cerebral cortex. Moving on, the oculomotor nerve is basically responsible for the extraocular movements. The trochlear nerve is basically again responsible for one of the extraocular muscles. Again, its basic function and its basic pathology would be found out whenever we ask the patient to look in the 6 cardinal directions. And that is basically going to highlight the fact that whether there is some sort of a problem which is attached to this trochlear nerve or not. One thing that I would like to mention over here is that we have the 3rd, the 4th, and the 6th cranial nerve, which is examined together when you are basically clinically examining the patient. We have the trochlear nerve, and it is basically supplying the superior oblique muscle of the eye, which is one of the extraocular muscles. And then we have the abducens nerve, which is basically the 6th cranial nerve, and it is supplying the lateral rectus muscle of the eyeball. So these 2 muscles are supplying these specific muscles, and apart from that, all of the extraocular muscles are supplied by the oculomotor nerve. So whenever we're going to check the 3rd, oculomotor, 4th, trochlear, and 6th, that is the abducens nerve, we're going to ask the patient to look in the 6 cardinal directions, and that is going to highlight whether there is some sort of a specific problem with these 3 cranial nerves or not. As we have discussed, the sense of smell can be checked by asking the patient and basically asking them and offering the patient, giving him the coffee beans or some specific smells and asking them to identify these smells, and that is going to check the olfactory function of these nerves. The oculomotor nerve is checked, and the trochlear and the abducens is checked. Then we have the optic nerve, and you can check the functioning of the optic nerve by basically asking the patient to read out the Snellen's chart. Then you can also check for the visual fields. And apart from that, you're also going to ask the patient to give you some specific signs regarding if there is some sort of a blurring of the vision that is noted in a specific part of the day or not. So this is all that you're going to check, and that is basically going to highlight any abnormality in the optic nerve of that particular individual. Then we'll be checking out for the facial nerve, the vestibulocochlear nerve, which is responsible for the hearing of the individual. So basically you use a test which is known as the Raynaud's test, and over here basically you use a tuning fork which is almost 512 hertz in the frequency, and you ask the patient if if he or she can hear the tuning fork vibrations or not. So this is how you check the both of the ears at one time, and this is how you check for the functioning of the vestibulocochlear nerve. Moving on, we'll be discussing the facial nerve as well and the pathologies along with that. But before that, in a normal individual, you should know how you're going to check for the facial nerve. So the facial nerve, as we know, it is going to perform you're going to ask the patient to clench the teeth, and these are the specific functions that the person is going to perform. Then obviously you're going to look for the trigeminal nerve. The trigeminal nerve has 3 major subdivisions, and you can touch for the pain and temperature, and that might be sufficient until and unless you have a specific history for that particular patient, and you know that this patient has some sort of a trigeminal abnormality. So then you're going to check for the motor component of this nerve as well. One thing that you have to keep in mind is that all of these cranial nerves, some of them have the sensory functions, some of them have motor functions. So some of these cranial nerves are purely sensory and some of them are purely motor in their function. And on the other hand, we have the mixed variety of the cranial nerves. For instance, one of the best example out here is the trigeminal nerve, which has a sensory component and as well as it has a motor component. So some of these nerves are going to have mixed functions involving the sensory as well as the motor components over here. So having these patients of cranial nerve disorders, sometimes it is very common to have them in your outpatient departments, and you must know what are the specific signs and symptoms that are related to these patients. These patients would mostly come up to you with the complaints of facial pain and numbness. They can come up to you with trigeminal neuralgia. So as I was discussing, the trigeminal nerve has basic 3 subdivisions. Majorly, we have the ophthalmic division, the maxillary division, and the mandibular division. So any of these 3 areas can be affected when the person is suffering from pain. And that is basically going to show that there is an inflamed trigeminal nerve that the person is having. Trigeminal neuropathies are there, and the patient can have different sets of signs and symptoms. Then we can have facial weakness that is observed in these patients. Bell's palsy is one of the most notorious condition that we usually come across. The etiology behind this kind of a condition is very important, and you must know what are the factors that lead to the development of this kind of a condition. So you would come across these different variety of patients that would come up to you with different clinical pictures. And as we have gone through the functioning of the cranial nerves, we know that, for instance, the glossopharyngeal nerve is supplying the tongue. Then we have the accessory nerve that is supplying the sternocleidomastoid and the trapezius muscle. So all of these, the vagus is supplying the heart, and all of these have different specific functions. Depending upon which cranial nerve is affected, the patient is going to have a variety of clinical pictures to you. Knowing the specific functions of these cranial nerves is the key here. So you must remember that what is the specific functioning of these cranial nerves, whether they are sensory or motor in their origin, or whether they are the mixed type of cranial nerves that we're going to talk about. So that is going to help you out in diagnosis of the particular patient, and obviously the management of these particular patients over here. So basically, we'd be going through the major clinical syndromes that we can encounter, and we must know how to identify these different clinical syndromes. Some of them are very common, and you would come across these patients in your outpatient departments, and there would be a typical history that is usually attached to these patients. They would be giving you the typical kind of history that would basically highlight what area is involved is very important over here, because you must be knowing that the trigeminal nerve has the three major subdivisions: the ophthalmic, the maxillary, and the mandibular. So if you have a patient of facial pain and he's also complaining of numbness in a particular area of this division, the skin of the face is involved, and the patients would usually give you the history of pain with even the slightest triggers. For instance, on the application of makeup, the patient would give you the history that a pain is basically triggered even by the slightest of the stimuli. For instance, brushing of teeth. So these are some of the instances that the patient would be really concerned about, and he would come up to you and give you the history that basically he's suffering from pain in a particular region of face. So this is basically going to make you cautious of the fact that we're dealing with a patient of a cranial nerve disorder. Now, you might be thinking, what are the causative factors towards this development of pain in these patients? So, there are different pressure symptoms. It can be the development of a tumorous condition that is basically applying pain in that particular area. It is applying pressure on the trigeminal nerve after it exits the skull. So, this can be one of the factors. And then there are a lot of autoimmune disorders. For instance, we have multiple sclerosis, which is one of the condition, and in these also patients have basically inflamed nerves, and that is basically going to cause the pain of the trigeminal nerve. So this can be one of the symptomatology, and these patients would give you a particular history. You're going to get a particular examination of these patients, and that is going to head the treatment and management in a particular way. Now, having known that we have these three major subdivisions, namely the ophthalmic division, so this pink area is basically showing the skin of the scalp, the skin of the nose, bridge of the nose is involved, the ali are involved over here, and then we have the maxillary division of the trigeminal nerve over here. So this green portion is basically signifying the skin of the face that is supplied by the maxillary division of the trigeminal nerve. And then finally, we have the mandibular division of the trigeminal nerve, which is basically involving the complete mandible, then the skin of the auricle, the external ear is involved, and a little bit of a skin of the scalp is also involved over here. So these are the areas that are involved, and any numbness or any pain that the person is reporting with is going to make you suspicious that this patient is basically suffering from some sort of trigeminal abnormality that is inculcating this pain, that is presenting the patient with this pain. And the underlying pathology is obviously going to be found out by further investigation in a particular manner. So the trigeminal nerve and its branches, we know that there is an ophthalmic branch which gives off these particular branches known as the maxillary branch, known as the lacrimal branch, and then we have the supraorbital branches, we have the supratrochlear branches, the frontal branches of the frontal nerve, we have the supratrochlear nerve, then we have the ciliary ganglion nerve. So these are all basically the subdivisions to the ophthalmic division of the trigeminal nerve. The infratrochlear nerve, Then we have the internal nasal rami. So this is how it is going to even supply the skin of the bridge of the nose, because it has a division which is known as the internal nasal rami, which is another branch. Then we have the external nasal rami, which is a furthermore branch to this nerve. Then the maxillary division of the trigeminal nerve is going to give off a branch and supply the alveoli as well, the nasal and the labial rami of the infraorbital nerve. Then we have the anterior superior alveolar nerves, which are the subdivisions of the maxillary branch. So the three major branches, the ophthalmic is subdivided into all of these particular branches supplying the different areas of the face. The maxillary is divided into supplying the lips and the alveoli. The gums are being supplied by this superior alveolar nerves. Then there is a lingual nerve, which is a subdivision, and it is giving off a submaxillary ganglion to it. Submaxillary and sublingual ganglion are present, and then finally we have a mental nerve, which is basically supplying the skin over the chin area. So these are some of the branches of the trigeminal nerve, the specific and the most significant branches, and would be depending upon which of the branch or which of the major branches affected, and the pain would be radiated in that particular area. So this is very important that you know these branches, because that is going to highlight the fact that which of these particular branches are being affected and giving off the particular clinical presentation. We even have a mylohyoid nerve, which is supplying the skin of the neck, even is involved up till the hyoid bone. The buccinator nerve, which is supplying the muscles of the mastication. The chorda tympani nerve is another branch. Then we have the pterygopalatine ganglion. And then we have the mandibular division of the trigeminal nerve that is shown over here. Ophthalmic nerve, which is one of the major branches. So the major branches would be the three, that is the ophthalmic, the maxillary, and then we have the mandibular division. And then we have a subdivision, a set of subdivisions is present out there to supply the skin of the face. The frontal nerve giving off the frontal branches, and the nasociliary nerve is present. We have the posterior ethmoidal nerves, and then we have the anterior ethmoidal nerves. So the trigeminal neuralgias, and how does it take place? What is the pathophysiology behind it? As I was already explaining, it can be any inflammatory condition which is giving rise to this pain. It can be any tumorous condition which is finally giving off this particular clinical picture in this patient. So it would be depending upon the investigations and the results of these investigations that you get, whether you have the radiological investigations done or the blood test being performed, and you move on to head your investigation in a particular direction. The pathophysiology may involve a chronic focal demyelination factor, and it would basically initiate the trigeminal neuralgias in these patients. Then it can be an ectopic a pathology that is present out there, an ectopic tumorous condition that is present, an impaired segmental inhibition, it is one of the factors. And all of these are basically going to combine together to give off the paroxysmal firing of the low magnitude interneurons in the trigeminal nucleus cells. So this is basically going to give off that neuralgia, that pain that the patient is experiencing in the patient. The paroxysmal firing of the relay neurons in the trigeminal nucleus cells. So there would be this firing, this twitching factors that are present, and that is going to give off the neuralgic pain by slightest stimuli even. And then finally, there is going to be an attack of trigeminal neuralgia. So these are the underlying factors. The triggering factors would be the relay neurons that are being inhibited. And then we have the paroxysmal firing as well of the interneurons in the nuclei of the trigeminal nerve. Now, this condition can be confused with a lot of other clinical conditions. For instance, we have the pain of the sinuses. So sometimes an inflamed sinus, and specifically a chronically inflamed sinus, can give you this typical picture of the sinus's pain. Migraine is one of the symptomatology or the set of symptomatology that presents with such a pain, specifically in the forehead region. And then there can be a cluster tic. They also resemble this kind of trigeminal neuralgias. Cluster headaches have specific pathologies, specific underlying pathologies, but the presenting picture can be quite confusing. And this can be one of the differential diagnoses that you have at your hands. Myalgias, due to multiple reasons, can be one of the underlying factors, and then we can have cases secondary to mass lesions. So tumors are one of the key factors over here, and one of the secondary picture, one of the underlying cause can be the development of the secondary masses that are basically applying pressure or putting a pressure on the trigeminal nuclei or on the trigeminal nerve and giving off a final picture of the trigeminal neuralgia in these patients. The laboratory evaluation can basically much more clarify the picture in this patient. So it is very important to rely on these tests and get to your definitive diagnosis. First of all, you would run the tests to identify if it is a case of multiple sclerosis that you're dealing with. An elevated ESR is one of the key factors that is basically going to identify the patient is suffering from some sort of an underlying inflammatory reaction or an infectious state. So the treatment of these trigeminal neuralgias, you can treat the patient. Obviously, consoling the patient is very important. Educating the patient towards the condition is very important. Giving him or her the core knowledge is very important. And then after the correct kind of a counseling, you can prescribe drugs, obviously. And that would include prescribing carbamazepine 100 milligrams daily. So that can basically not completely allay the symptoms, but it can make the quality much more better. Then we can have the oxcarbamazepine, that is almost in a dose of 300 to 1200 milligrams BID. So we have these group of drugs being commonly prescribed for the condition which is known as trigeminal neuralgias. So you must go through this factor that whether you have this definitive diagnosis or not. And you must always rule out the other differential diagnosis before prescribing any of these drugs. So having a definitive diagnosis in your mind is very important over here, and you have to focus on this fact particularly. Surgical treatments are also prescribed. For instance, we can prescribe suboccipital craniotomy. The gamma knife radiosurgeries are very commonly done these days, and because of the fact that they are the minimally invasive surgeries that are being performed. Then we have the rhizotomies being performed, and then we can also resort to the magnetic resonance angiographies, which are one of the ways that we can surgically treat these trigeminal neuralgias if they are not responding to the oral drugs, if the patient is not responding quite well to the carbamazepine or oxcarbamazepine. So you can resort to these surgical treatments as well. The trigeminal nerve disorders or the trigeminal neuropathies are one of the clinical pictures that you would come across. The reasons behind, we can have nuclear lesions, then we can have the preganglionic lesions, or either the patient can also give you the Gasserian ganglion lesions. So after that, we can have the peripheral nerve lesions. So these are the group of different underlying pathologies that can result in the trigeminal neuropathies. Either the ganglia are being affected, or there is some sort of an underlying pathophysiology going on with the ganglion, or there is an inflammatory reaction that is going on over here. So these can be some of the clinical pictures or some of the clinical pathologies underlying this factor. Nuclear lesions, as I was talking about, it can be the condition of the syringobulbia. Then we can have the gliomas. These are basically the tumorous conditions depending upon the histopathology of the patient. So you always sometimes resort for this kind of a histopathology if you want to be more sure about it. Stroke can be one of the underlying cause. Then multiple sclerosis is one of the autoimmune disorders which can present to you with such trigeminal nerve disorders and then some of the lymphomatic conditions. Either it can be a viral condition or it can be a benign condition, benign tumorous conditions, which can basically result in this kind of a trigeminal neuralgic conditions. The preganglionic lesions include the acoustic neuromas, so it can be one of the state. We can have the meningiomas, we can have the METs that can travel up from the kidneys, from the lungs, from the distant organs, and they can resort to the brain and finally pressurize the trigeminal nerve. So these are basically the distant organs affecting the brain and giving you a picture of trigeminal neuralgia. On the other hand, the underlying pathology is quite distinct. So the investigation has to be led in a particular direction to get to a definitive diagnosis whenever you have these patients of trigeminal pathologies at your hand. Chronic meningitis is one of the cause over here. So it has to be investigated. Then the patients with cavernous carotid aneurysms, they sometimes present with this kind of a trigeminal nerve disorder. Basically, the pressure symptoms are the basic pathophysiology behind all of these conditions. The pressure applied on the trigeminal nerve is going to give off the particular set of sign and symptoms in these patients. The Gisserian ganglion lesions are present and they are as a result of the trigeminal neuromas. Then we can have the herpes zoster, which is one of the infectious states, and the infections which are spread from the otitis media, or even the mastoid bone is sometimes involved, and any kind of a chronic infection involving the mastoid bone giving off the mastoiditis is going to give off this clinical picture of Gisserian ganglion lesions. The peripheral nerve lesions can involve the nasopharyngeal carcinomas in the patient, and obviously we can have the traumatic conditions seen in these patients. We can have the Guillain-Barré syndrome. So some of the syndrome, Georgian syndrome, Guillain-Barré syndrome, they are sometimes seen, and whenever it's basically they're mostly the autoimmune disorders. So Georgian syndrome is one of the autoimmune disorder in which the patient is going to have dry eyes, and even the salivary glands are involved, and the patient also sometimes present to you with a dry mouth. So the set of symptoms are going to be observed in particular, and that is going to basically make the picture more clear whether this is some type of a syndromic condition that the patient is having and is finally affecting the trigeminal nerve and giving off a particular pathology. The collagen vascular disorders, we have the idiopathic trigeminal neuropathies. Leprosy is one of the conditions seen in the patients, and that is sometimes coupled up with the trigeminal pathologies as well. Patients with some sort of illicit drug use would also come up to you with this kind of a history. And then we have patients of sarcoidosis also coming up with the trigeminal pathologies. Now, sometimes apart from pain and numbness, the patient would present with facial weakness involving a single side of the face, or even it can involve the lower half of the face, sparing the upper third portion of the face. So whatever the case is, you have to take the complete detailed history from the patient. A lot of things are going to be self-explanatory in this kind of condition. For instance, a patient of Bell's palsy would present with a drooping eyelid and a drooping side of the lips, and there would be a particular history of exposure to cold in these patients, or certain history of recent infections in the past. So this is very important to take the history in detail over here, and any previous history of such episodes or not, because this is going to basically narrow down the conclusions in these patients. The anatomical considerations over here would be the facial muscles are going to be taken into account, and the nerve supply to these facial muscles is very important over here. Bell's palsy, you would come across these patients, and drooping eyelids, drooping lower lip would be the particular clinical features that you would observe. The patients would give you a history of ear pain. So sometimes the triggering factor can be the ear pain. And basically, the drooping lid or the drooping side or the drooping corner of the lip is overviewed by the patient himself until and unless someone else notices it. And that is why the patients would usually say that we have an ear pain and they would come up to you. The paralysis is noted down in these patients, and then we have the taste sensations are lost on the contralateral or either on the ipsilateral side of the face. Then we have the hyperacusis. This is one of the triggering factor over here. Then we have the cerebrospinal fluid lymphocytosis. So checking out for these positive signs and sending the blood samples for the histopathology and noting down this lymphocytosis in the CSF is very important. The swelling of the geniculate ganglion, if you can have the studies done particularly, and then the patient can also have the facial nerve swelling in these patients. The axonal degeneration is also noted down in these patients of Bell's palsy particularly. Now, the underlying pathophysiology would be very interesting over here. Now, it is again very important that the Bell's palsy can involve the complete side of the face, or either it can involve just the lower half of the face. So if it is an upper motor neuron lesion, it is just going to involve the lower half of the face. And in case of the lower motor neuron lesion, it is going to involve the full complete side of the face. The corticobulbar tract is involved over here, and there is basically a crossover at this level of the lower motor neuron lesion. So if there is an upper motor neuron lesion inside the corticobulbar tract, then it is just going to affect the lower 1/3 of the face particularly. And if the nucleus of the cranial nerve, that is the 7th cranial nerve, is involved, and it is going to be known as the lower motor neuron lesion. So to differentiate, and what is the condition that we're going to term as the upper motor neuron lesion, in which the corticobulbar tract is involved, and in which a condition in which the nuclei of the facial nerves are involved, we're going to term it as the lower motor neuron lesion. And even the cranial nerve itself can be damaged in a lot of cases. So the differential diagnosis over here would be, it can be a state of Lyme's disease. Patients with Ramsay-Hunt syndrome would particularly present with a typical picture resembling a Bell's palsy. Patients with Guillain-Barré syndrome, patients with leprosy, when we have the Sjogren's syndrome, would sometimes present to you with a similar history, and then we have the Melkersen-Rosenthal syndrome. So these are some of the syndromic conditions which can present with a similar condition just as Bell's palsy. And so it is very important just to have a look at these signs and symptoms and know the particular factors in detail over here. The laboratory evaluation would basically rely upon the patients with a typical presentation, no risk factors or pre-existing symptoms, or there is an absence of cutaneous lesions of herpes zoster. So having the history in detail and then obviously examining the patient in detail over here is very important. And you're also going to rely upon the neurological examination except the facial nerve over here. The evaluation would consider the ESR being taken, testing for diabetes mellitus, and then we would also consider doing a Lyme's titer over here, performing an angiotensin converting enzyme test. We'd be looking for any chest imaging studies being performed, lumbar puncture is being performed over here. Just to rule out the specific other factors over here, the differential diagnosis is made, and then obviously the radiological investigations are going to reveal a lot of factors. A facial nerve inflammation can be seen over here. So this is again very important to particularly see these factors, whether the lateral geniculate ganglion is involved or whether it is some sort of a corticobulbar tract that is involved over here, and that is basically going to further clarify the picture over here. The treatment would consist of glucocorticoids in the patient, and then we'd be giving off the prednisolone. The dose would be almost 60 to 80 milligrams daily for 5 days. And then we'd be also prescribing the antiviral agents. They are just the prophylactic agents being prescribed over here. So you would be giving the valsyl clover, 1000 milligrams daily for 5 to 7 days, acyl clover, 400 milligrams 5 times daily for 10 days. So this is a very high dose that you're giving acyl clover in a dose of 400 milligrams 5 times daily for almost 10 days, and just to cover up the prophylactic management, the antiviral therapy in these patients. Now we can give a combination of prednisolone and valsyl clover as well. So this is very important to keep this in mind, and surgery is sometimes done for patients who are resistant to this oral therapy. Other motor disorders of the face would include the hemifacial spasms, and there are multiple reasons to the development of this kind of a condition. It can be a motor disorder, so you would basically go through the factors which are responsible for the development of this condition. If it's an autoimmune disorder, you're going to treat it like that, or if it is an viral disease that is causing the significant picture, then you're going to treat the patient in a particular manner. Carbamazepine is given, and we can also prescribe gabapentin if it is also a painful condition. Then you're going to give, and then we can have the baclofen that is prescribed for these patients. You'd be considering the botulinum toxin as well in these patients. Then we have blepharospasms, and basically it can hinder the vision of the individual as well. Usually the botulinum toxin is involved over here. The facial myokymia, in which there is a facial discrepancy seen in mostly in children, and there can be a lot of traumatic causes. Birth trauma is one of the major factor over here, so you'd be considering this fact over here. The facial hemitrophy is also considered, and the single most treatment that is done for such a case of facial hemitrophy is the plastic surgery which is being performed for these patients. So it is again very important just to look for the underlying factors as well, whether it is a condition which can be reviewed through the drugs. Obviously, the oral intake of a lot of drugs can improve the condition in a lot of states. Then we can have the glossopharyngeal neuralgias in patients, and as we all know, glossopharyngeal nerve is supplying the tongue as well, the floor of mouth as well. So the symptoms would have the particular features of dysphagia as well. Dysphagia is one of the particular picture that you may come across in a lot of conditions. When you check for the functioning of the glossopharyngeal nerve, you usually ask the patient to produce the word ah, or you would be basically looking or checking for the gag reflex in these patients. So if there are any sort of pathologies that are involving the glossopharyngeal nerve, it is going to be usually presented with this particular features of dysphagias in these patients. Now, the dysphonia, that is the change in the voice, is one of the features. And again, it is due to the involvement of the cranial nerve, and the specific cranial nerve involved over here is again the glossopharyngeal nerve. So it can be one of the typical features. Dysphagia is one of the feature, dysphonia is one of the feature, and these are the clinical presentations that are related to it. The neck weaknesses are sometimes seen in a lot of patients, and as we know, when we are checking for the accessory nerve, we'd be particularly looking for the sternocleidomastoid muscle, and you usually ask the patient to shrug the shoulders. And sometimes when you are looking for the functioning of the sternocleidomastoid muscle, you ask the patient to revert the neck, or either you ask the patient to shrug the shoulders, and that is going to look basically you're going to look for the signs of any trapezius weakness over here, and which is also known as the sometimes presented to you with neck weakness or shoulder weakness in these patients. Then finally, we have tongue paralysis, and it is also seen in a lot of patients. The hypoglossal nerve is sometimes mostly involved over here. The cranial nerve syndromes that you usually come across are summarized over here. The sites involved are the sphenoid tissue, most importantly. And over here, we have the third, fourth, the first division of the trigeminal and the sixth cranial nerve. The lateral wall of cavernous sinus is involved, which is giving off basically it is being supplied by the third, fourth, fifth, and the sixth cranial nerve. The retrosphenoid space, it is being occupied by the second, third, fourth, fifth, and the sixth cranial nerve. The apex of the petrous bone, the cranial nerves involved over here are the fifth and the sixth cranial nerve. Internal auditory meatus occupies basically the seventh and the eighth cranial nerves are present over there. We have the pontocerebellar angle, in which we have the fifth, seventh, and the eighth, and sometimes the ninth cranial nerve. The jugular foramen, in which we have the ninth, 10th, and the 11th cranial nerves. The posterior lateral condylar space, which is accommodating the ninth, 10th, 11th, and the 12th cranial nerves. So as we can see over here, that these are the set of cranial nerves that we're going to come across. And if there is some sort of an abnormality, or if there is some sort of a trauma which is related to this posterior retroparotid space, which is occupying or accommodating the ninth, 10th, 11th, and 12th cranial nerve, it is going to give off a syndromic condition which is known as Horner's syndrome. So these are some of the conditions which are summarized over here. The multiple cranial nerve palsies involved, we have vernix encephalopathy, cavernous sinus syndrome, sarcoidosis, cavernous sinus thrombosis. Trauma is one of the factors which can lead to such conditions. Then we have a lot of granulomatous diseases. We have a lot of localized infections, Malchiari malformations, which are basically the vascular malformations, either congenital or acquired. We can have platybasias, and we can have the Guillain-Barré syndrome, which usually present to you with the cranial nerve palsies. Infections such as tuberculosis and Behçet's disease are some of the conditions which can present to you in the clinical departments with the multiple cranial nerve palsies. So over here in this lecture, we just went through and summarized the different common cranial nerve palsies or the cranial nerve pathologies that you would come across. So that is the end to this lecture. Thank you for watching sqadia.com.